Hi, my name is Nandiyini Bhardwaj. I'm a neuropsychologist and a cognitive neuroscientist at MindfulTMS, where I'm actively involved in research with rTMS and its applications in psychology, psychiatric cases, and neurology. For those of you who don't know rTMS, it's a very safe and non-invasive method where we pass mild magnetic stimulation on the scalp, which feels like a tapping sensation. This in turn increases or decreases activity in the brain cells and alleviates symptoms. Today I'm here in conversation with Dr. Guruprasad, who is the director and lead consultant in neurology at KIMS Hospital, and he's the head of movement disorders and Parkinson's disease program at KIMS. Doctor, let's start with having you introduce yourself a little bit, and let's dive into your journey as a neurologist and your experience with neurology as a subject.
Thank you, Nandini, for having me for this podcast. I finished my neurology training at Jaslow Hospital, Mumbai in 2004, and it's been 22 years since I've been practicing neurology in various hospitals in Hyderabad and then in Bangalore. My primary interest has been movement disorders and Parkinson's disease. I got training at Kiel University, Germany for DBS, and also did observership under Dr. Guruprasad, who's the director of neurology and movement disorders at Kiel University. So over the years, I've been doing actively botulinum toxin injections for various movement disorders like dystonia, writer's cramp, hemifacial spasm, and a keen interest in Parkinson's disease. So we've been doing, regularly deep brain stimulation surgeries. I and my colleague at KIMS Hospital, Dr. Garam, previously at Manipal Hospital and Fortis Hospital.
Okay.
We've been doing regularly, deep brain stimulation surgeries for Parkinson's disease and various movement disorders. The experience is very, very learning and enriching, because all along the way we face a lot of challenges. How to handle patients, difficult patients, but seeing them improve post these type of treatments. Having said that, even medical treatment is still holds a big role in management of these Parkinson's disease patients.
Right.
But when you reach a stage where the medication don't work and you have an option of deep brain stimulation surgery, and then the quality of life changes, and then you add one more layer of improvement in their lives. Right. I think that's very, very satisfying. So that way, the journey has been very, very fulfilling. A lot of things to come up, and I'm waiting for new technology to come in, both in DBS and of course today's topic about rTMS. It's a new kid in the block.
Yes.
I think quite exciting times to be in neurosciences.
Absolutely. And the getting together of rTMS, neurostimulation techniques, and deep brain stimulation and pharmacological techniques, all of this together creates a very wholesome modulation approach.
Correct. Yeah.
Okay. So let's talk about the indications of neurology when it comes to using rTMS for neurology. What are the indications that doctors should be looking out for?
Yeah. So when I was speaking about DBS, of course, it's an invasive type of neuromodulation, and it's been proven beyond doubt that it is effective in improving motor symptoms, be it bradykinesia, rigidity, tremors, and of course related complications like motor. Why we need to do all this advanced therapies is because over the time Parkinson's disease is a progressive problem. We all know it's a neurodegenerative problem, and medications work to a certain extent. Beyond that, most of the patients do develop complications, motor complications. There is something called wearing off effect. The effect of the medication goes off, and you need to make adjustments in medications. They develop medication-related side effects like involuntary movements like dyskinesias. They develop psychiatric side effects, and then they keep on taking medications. That becomes a challenge, and also develops other non-motor complications like memory disturbances, depression, a lot of pain, and then involuntary movements itself can make them lose balance and falls. So they progress, significantly. So that's where the advanced therapies, be it DBS, or there we have few more options, or like apomorphine therapy, or there's one thing called levodopa. So we use these advanced therapies in patients who think. But there is also a gap where we require either a bridge or non-invasive treatments. So in that field, we have a recent, evidence of what is called MR-guided focal ultrasound.
Right.
So we have new treatment modality called MR-guided focal ultrasound, which again is a non-invasive treatment where you use a focal ultrasound to create a lesion in the brain, and that can relieve a thing. But again, there are very select few patients who can benefit with this therapy. But that's again a very good, a mode of non-invasive treatment.
Right.
So coming to rTMS, it's not new. It's been there for many decades, and it's been studied in various psychiatric indications, initially depression, OCD, and all. And neurology, various indications have been studied, like Parkinson's disease, stroke rehabilitation, migraine, epilepsy. So various, in fact, cognitive dementia has been studied, but there is no long-term randomized controlled trials happened in a big numbers.
Right.
So the big RCTs are missing in thing. But having said that, there are good number of patients being tried on rTMS for various indications. We have good evidence for using of rTMS in migraine. In stroke rehabilitation.
Right.
Whereas in other indications like Parkinson's disease, epilepsy, the evidence is evolving.
Yes.
They have studied some 50-60 patients in single centers. A couple of them have been in multi-center studies and all. So the evidence is evolving. There is a modest improvement in the motor scores, specifically speaking of Parkinson's disease. There is a good improvement in the UPDRS thing, especially in bradykinesia and rigidity.
Yeah.
Tremor is not very consistent, but in coming to bradykinesia and rigidity, there is improvement. There is also, they have found that there is improvement in terms of non-motor symptoms. Like most of these patients also have depression.
Yes.
They have a low mood. That is also known to help. And some patients have benefited with being more alert. Then their cognition also has helped by non-invasive stimulation.
Right.
So even though it has been there in many years, but now there is renewed
Slowly
interest,
gaining traction. People are knowing about it.
So I think probably more and more centers will take it up.
Yeah.
Because important is it's non-invasive. It is being made available more freely now. A lot of companies are, including your company, Mindful. So who are interested and invested in this type of therapies. So that becomes easy access thing.
Right.
And we know that it has already been approved for psychiatry indications.
Yes.
So that way it becomes a win-win situation.
Absolutely. And it's very good to know that a lot of neurologists are slowly becoming aware of such modalities so that they can start using it in their application.
Yeah.
So before getting into more rTMS treatments for neurological diseases and Parkinson's disease, let's first understand what exactly is Parkinson's disease and how does one really know when they're starting to develop Parkinson's disease?
Correct. So in Parkinson's disease, as we all know, it's a neurodegenerative condition, one of the commonest neurodegenerative conditions. So it's essentially a motor syndrome where patients develop tremors, slowness in movements. Usually one side of the body is involved and then the other side get involved over years. They become rigid and they lose balance. They tend to fall. Their speech becomes low volume, and they also develop non-motor symptoms. Sometimes, in fact, non-motor symptoms can start before the motor symptoms. Some of these patients do have what is called REM sleep behavioral disorder, like they have sleep talking, they enact during sleep, they enact dreams during thing, they have sleep talking, they can fall off from the bed, that can precede the motor symptoms. A lot of patients do have constipation before the actual motor symptoms come. They may have anosmia. And later, the non-motor symptoms also accumulate over time. They can become depressed. A lot of patients complain of severe pain, sleep issues. So all that can happen. So it's not just motor symptom. It will predominantly it starts as a motor symptom, but there is a lot of non-motor symptoms happening. So it's more like a syndrome. So if you're asking me, so what happens in Parkinson's disease? There is a degeneration of nigrostriatal neurons in the brainstem. And there is a dopamine deficiency, and that's the reason why there is an imbalance in the output to so the networks what controls our motor movements. There's something called direct and indirect motor circuit. So there's an imbalance of that. So the indirect motor circuit becomes more active, and that's the reason why patients become slow and they develop tremors and all. And physiologically, there is known that there's a lot of beta oscillations between 12 to 20 hertz, abnormal oscillations, and there is a little bit of cortical hypoactivity. So the circuit or the circuit or the networks, the striatal, cortical, thalamic circuit, what we say, is become a little bit abnormal, and that's the reason why you see this type of symptoms. So how do you recognize symptoms in Parkinson's disease? They can present in different way. Every Parkinson's disease patient is different. Some patient can just come with the pin rolling tremors, one hand tremors. They can have tremors in the legs, or they can have just a lower jaw tremors. Some patients can present just with frozen shoulder. That is reflective of the stiffness or rigidity in the limb. So they can go to orthopedician. They can just come with a stoop posture. So I think the presentations varied. But as a neurologist, as a movement disorder specialist, we can sense that when they come into the room, we know that there's something wrong in the gait because they drag their legs while walking, or they have this tremors thing. Sometimes they'll be accompanying their family members. They would not know they have Parkinson's disease, but we question them when are you having this type of things? So that can be very subtle. So, but diagnosis is purely clinical. We don't take help of any investigations, unlike other diseases where you require a lot of investigations to support your diagnosis. Parkinson's disease diagnosis doesn't need things. So you have the core feature of Parkinson's disease is bradykinesia. So you look for slowness in movements. One thing is visible on what you watch, and also examination of motor movements. If you can establish there is bradykinesia, along with that you have rigidity and tremors, the diagnosis is made. And typically is asymmetric. One side is affected first, and the other side gets affected. So it's essentially a clinical diagnosis thing. But when you have, like for example, red flags. So your question about Parkinson plus and Parkinson's disease. So when there are red flags, like you say, the patient has imbalance very early on. In a typical Parkinson's disease, we look at imbalance very late, after 5 years, 10 years, and all. But someone has loss of balance and recurrent falls very early on, or there is symmetrical involvement. So then you tend to look for Parkinson plus syndrome. Or if there is any orthostatic autonomic dysfunction, for example, they feel dizziness on getting up very early on. Later is fine, but very early on, first year, second year, they have this type of symptoms, or urinary incontinence. Axial symptoms tend to fall backwards, lose balance early on. On examination, if we find signs like slow eye movements, then we make a diagnosis and early speech involvement. So there are certain red flags we look for. If we see that there is that type of things, we go into more details. There we require help of imaging. But again, early stage, it may be difficult. And another pointer towards Parkinson plus versus idiopathic Parkinson disease is also levodopa responsiveness. The response to medications. That is also a very good indication. Early on, both Parkinson plus, even Parkinson plus also respond to levodopa. But with with 1 year, 2 years, the response becomes muted. But levodopa responsiveness is preserved in idiopathic Parkinson's. That's also a good indicator.
Right. So extending on to what you're saying about there are medications only work up to a certain extent. For a lot of cases, they may work to a certain extent, but there may be some dyskinesia-like symptoms later on. Can rTMS help with that? So coming back to rTMS use for Parkinson's specifically, now that we know the red flags for Parkinson's, how can rTMS tackle the challenges that neurologists face with common traditional methods of treatment?
So definitely there is a role of rTMS in treating Parkinson's disease things, but the role of the drugs, especially levodopa, even after 50 years of making it presence, it still remains the gold standard for treatment of Parkinson's disease in terms of medications. Having said that, as I mentioned earlier, patients do develop motor complications. They develop wearing off effect. On and off phenomenon, delayed on, they don't get an on thing, and then this phenomenon becomes unpredictable over time. So that's when we look at advanced therapies, including the first choice would be DBS, invasive therapy like DBS, where we can either target STN or GPI, and then improve these motor fluctuations, reduce dyskinesias and all. It's been proven beyond doubt. But there is an area where there is probably the patients are not eligible for DBS. Patients don't want invasive therapies, or patients are bad candidates because the disease is advanced, or the patients are above 75 years of age. They also have developed cognitive issues.
Okay.
There is already some amount of depression setting in. So then they become not a good candidates for surgical intervention.
Okay.
So that is when we can look at alternative treatments like rTMS, especially in idiopathic Parkinson disease.
Okay.
So the studies I already mentioned, that studies have shown that the effect of rTMS in Parkinson disease is modest but significant. So there is a significant lowering of epididymis motor scores post TMS. So usually we subject them to repeated cycles. As you already mentioned in your introductory remark, that usually we give cycles of at least 1,000 to 3,000 cycles.
Low or high frequency?
Low frequency or high frequency. So low frequency is less than 1 hertz. But in Parkinson disease, typically you give high frequency. So when you do that over time, so usually they say more than 10 rounds of stimulation do help, and the effect can last anywhere between 8 weeks to 3 months. So probably we can consider repeating. So we don't have robust data how to go about that.
Yes.
That's where the evidence is lacking. So we know it works, but how long and what to do next is probably we need guidelines on that.
Right.
So there is a modest improvement. I think there is a role for rTMS in select patients. And I think if you choose it properly, definitely we can improve their thing. And that helps in terms of reducing the medications to a certain level, and medication-related side effects can come down. Even when you look at improving their mood, improving their depression, cognition, so that related medications also can come down, which again has an adverse effect on the patient's overall being.
Right. So motor and non-motor, both symptoms can be dealt with rTMS.
Yes.
However, the first step in identifying whether somebody has Parkinson's or not is to go up for a consultation with a neurologist.
Yes.
Whenever they feel like they might have one of these symptoms, they should get it checked.
Yes.
Right. And then once they're in front of you telling you about your symptoms, you choose the best modality, whether it's a combination of all or whether it's selected.
Yes.
And then present them with the treatment options.
Yes.
Right. So let's say somebody has chosen rTMS along with ongoing therapy and medication. And they've started taking the rTMS sessions. What are some of the first changes they notice after, let's say, 5 sessions or 10 sessions?
Yeah. So as I mentioned, the effect is mostly seen in terms of bradykinesia and rigidity. So the improvement in terms of limb movements, the gait, walking abilities, that becomes visible. You typically after 8 or 10 cycles, you see that there is improvement in the movements and all. And then you can see that we have seen in our series also that there is improvement in the alertness. So they're much more, because one of the feature of Parkinson disease which can't be measured is the fatigability. So that fatigability comes down. They're much more alert, because after all you are stimulating the cortical thing. We are not reaching the basal ganglia. We're trying to modify the cortical circuits here when you're doing rTMS, when we're putting a coil over the surface of the thing. And especially you're in Parkinson disease, there are 3-4 areas where you stimulate. That is a motor area, M1 area, or supplementary motor area, or a little bit frontal, dorsolateral, prefrontal cortex. So all these are the areas for stimulation in Parkinson disease. So when you do that, so not only that the movements become much more brisker, their gait improves, their arm swing improves, there is also improvement in terms of reduction in stiffness, the rigidity, and that translates into reduction in pain. So that we look at that. And sometimes we do also stimulation of supplementary motor. So there the posture, the gait, axial symptoms also improve. Freezing improves with that.
Right.
Yeah.
Okay, that's good to know. So it's a series of events, and they notice changes, and it could be different for everybody.
Yes.
So there are always individual differences.
Yeah.
Right. And you also talked about the target areas that we choose for with rTMS and Parkinson's. So it's supplementary motor area. There's DLPFC, dorsolateral prefrontal cortex.
Yeah.
And are there any new rTMS protocols, any new regions that are currently under research?
So in some of these patients who have Parkinson plus syndromes, like predominant cerebellar features, speech or ataxia and all, there is also a role of stimulating cerebellum, bilateral cerebellum.
Right.
So that also can be thought of if there is a predominant cerebellar features.
Okay.
But if there's predominantly motor, bradykinesia and rigidity, these are the areas which can be stimulated. Thing. And usually we typically use high frequency stimulation in these patients.
Yes. Right. So you mentioned Parkinson's plus syndrome and Parkinson's disease.
Yeah.
What is the difference between the two, and how do you know which one you have?
Yeah. So there are different types of Parkinson plus syndromes.
Right.
So there is something called PSP, progressive supranuclear palsy. Again, in PSP there are some 2-3 clinical phenotypes.
Okay.
One can present with the typical Scheidegger syndrome, where you have recurrent falls. There is a dysarthria, dysphagia, supranuclear gaze palsy. So this is the typical PSP-like phenotype. There's also another phenotype which just looks like exactly like Parkinson's disease, but symmetrical disease, poor postural control, some levodopa responsiveness and all. And there is also other type where they have predominantly gait freezing. So this is one PSP thing. Whereas there is also something called multisystem atrophy. So again, in multisystem atrophy, there are 2-3 clinical phenotypes where you can have predominantly autonomic dysfunction, a lot of autonomic dysfunction in the form of urinary incontinence, have orthostatic giddiness, blood pressure dropping, have syncopal attacks. Or there is, as I mentioned, about cerebellar type. And there is a Parkinson type. So Parkinson type of my MSA looks very similar to the idiopathic Parkinson disease. But there are subtle differences where the disease is symmetrical, more rapidly progressive. The non-motor symptoms are much more faster, and the response to levodopa is muted. Within 1 year, 2 years, they don't respond. However, higher doses, and they don't tolerate the medications also. They can have orthostatic drop in blood pressure. So all that can happen. So these are the things. So as I mentioned, when we follow them up, whether it is a typical Parkinson disease or atypical Parkinson disease, we follow them up regularly. So when we see these atypical features, setting in, because we need to examine them in detail, apart from the history taking, we examine them, we look at, early falls, then our, antenna goes up. So we don't expect that to happen in idiopathic Parkinson's. So as a movement disorder specialist in Parkinson disease, if something happens very, unusual, in course of the disease, then our antenna goes up, and then I think then we take help of, investigations like MRI brain, or sometimes we use, but unfortunately the functional nuclear scan doesn't help differentiate. So we again, those structures, the uptake is the same. So it may not, only thing asymmetry versus symmetry may be a little bit helpful, but otherwise it's mostly depending on the clinical thing and the progression of the disease. So the decision is very important. I mean, the differentiating Parkinson and Parkinson plus becomes very important, because we know for sure that Parkinson plus syndromes don't respond to advanced therapies. They're not the candidates for deep brain stimulation. So we will have to manage them with medications and supportive care. So the progression is faster. The caregiver's help is much more required. They require much more assistance than Parkinson disease. 24/7 caretaker is required, because they have poor balance. They may fall. There are high risk of fractures. So in these patients, they will develop swallowing difficulties. So someone is there to guide them to swallow, feed. So small requirements becomes challenging, and they require assistance.
So we were just discussing the distinction between typical Parkinson's and atypical Parkinson's. So can you tell me a little bit about what treatment modalities, what options are there for somebody with an atypical Parkinson's?
So the options are very limited. We use dopa drugs like levodopa and other dopa agonist thing, but maybe in a lesser quantity or lesser dosing, because the tolerance is very poor in these patients, and then we have to quickly back off because they develop side effects, whether it is autonomic dysfunction like drop in blood pressure or a lot of GI symptoms related to medications and all. So we use very low dose dopa drugs in these patients, and we soon realize that they don't tolerate. And then nothing. So there is a thing. So it is mostly supportive care, where we need to take care of each aspect, like avoid falls, have a system in place, train the caregiver that they avoid falls. The way we take care of the GI problems like constipation, swallowing issues. Some patients go on to RT or, PEG tube feeding later on. So, and they need to be on supplements so that, their bone strength, bone health is taken care, calcium, vitamin D supplements, B12 supplements, all that things, more of a supportive thing. That way it's very limited. I think that's one where so there's a gap where we can fill in with this type of non-invasive therapies, because there were some studies of PPN stimulation, DBS, for patients with PSP.
Okay.
But we didn't have much response there. So the studies have shown that DBS doesn't help patients with Parkinson plus syndromes, be it MSA or PSP. So there's a gap where we can look at these non-invasive treatments like rTMS, and with whatever little bit of experience I've seen. Definitely we have seen improvement in terms of mobility, the posture control, the balance has improved in few of our patients we have tried. The speech has improved, the swallowing has improved, and as I mentioned in Parkinson disease, there's also improvement in alertness. So the attention span is improved, because that becomes important for them to participate in the physiotherapy and all. Because these patients require a lot of physiotherapy training, balance exercises, and all. So if they're not alert throughout the day and they get fatigued and then they get tired easily, their participation in the therapy comes down. So in a way, it's a thing. In either MSA patients or PSP patients, some of the PSP patients a little advanced, we may not respond well if there's significant amount of brainstem involvement and recurrent falls. Maybe even rTMS may not work, but in certain subset of patients with Parkinson plus syndromes like MSA, P, patients with gait freezing type of PSP, there's definitely a role where we can target supplemental motor cortex, prefrontal cortex, and then improve their gait, because there's a wider degeneration of these networks in these patients with Parkinson plus. So their executive functions are impaired. So if we can improve their executive functions, the networks are inactivated, then there is a role for rTMS. And in whatever small experience we have, I think we are seeing that. I think we probably can pool the data. We're planning to pool the data and probably publish it. And there are centers who are doing that. And then we can take the cue and then probably rework our target and all.
Right, absolutely. So rTMS doesn't really make new neurons. Essentially, it just revives the previously, dopaminergic system that was not working properly. Correct. So it remodulates.
Right.
So it helps with bringing back the balance between the direct and indirect pathways. It helps with the neuroplasticity, and it helps with balancing the cortical excitability.
Right.
And it's a good thing. The more neurologists come to know about this treatment, the more data pool we'll have, and the more research we can publish to increase the evidence base. And we're also actively working on research together, so it's a good thing. And you also mentioned about supportive care. So I am also curious to know how supportive care, in the terms of how can the caretaker better implement some strategies to take care of a person with Parkinson's? And also, is physiotherapy something that can come into the picture along with rTMS?
Yes, very good question, because rTMS can be complementary or otherwise as well. The physiotherapy, speech therapy, occupational therapy, becomes complementary to rTMS. So the role of caregiver is very, very important. First thing is to make them understand, sensitize about the disease, because there is caregiver exhaustion happening. So once they are sensitized and then they participate actively in terms of taking care of their near and dear, so it becomes very easy for the treating doctor. So ultimately, their role is very important. First thing is to administer the medications on time. So, not only just Parkinson plus, but Parkinson disease requires very frequent dosing. So it's almost like every 2 hours, 3 hours. So their role becomes important. And some of these patients have problem with remembering their taking their medications and all. So their role becomes important. First thing is to make sure that medications are given on time. The next is to make sure that the home is designed in such a way, the furniture is designed in such a way that these patients have easy movement. So mobility is more easily taken care. the common usage area like washrooms, their bedding, all that is taken care. So there can be easy transfer of these patients from bed to chair or chair to standing, walking and all, having places where they can hold on to. Now I'm speaking about more advanced patients, patients with advanced Parkinson disease. Early on, they're very independent, so we don't need all those things. They're quite active as you and me. But once the disease advances, then the role of caregiver becomes important. And then this type of supportive measures becomes important. Then comes the feeding part. Then their toilet training or I think all that becomes important. So their support is very important and avoid falls. So their role and their participation is very, very, very important, especially if someone has Parkinson plus syndrome as compared to idiopathic Parkinson disease.
Right. So you said these are for advanced Parkinson's. So I want to know, does rTMS also have a role in, when somebody has early Parkinson's or whether they have late Parkinson's? Does the improvement, rTMS-based improvement, really change depending on when you start treating it?
I'm not sure whether the rTMS has been tried in early Parkinson disease. As I mentioned, the initial treatment will be medical treatment. Even for invasive therapies like DBS also, we wait at least for 5-6 years. Only once the motor fluctuations or motor complications set in. Earlier it was too long wait. We used to look at as a last resort. But we have now evidence to say that we can do it early on. So we have trials, what is called early STIM trial, which showed that once within 1 year of starting of motor complications, you can take these patients for invasive stimulation. I think I would place rTMS also there, where you can look at mid-level. There's a window in subacute or not. Don't call it subacute, but where you have 4-5 years of disease, the patients do develop complications, motor complications and all. So when you're looking at considering invasive stimulation thing, waiting for that, you can look at it as a bridge. The patients are taking time to decide. You can look at it as a bridge, or as I said, if they are not candidates for invasive therapies or they don't want things, then this acts as a complementary for medications plus the physiotherapy. So that would probably place. But if you wait too long, if it is too advanced treatment, advanced disease where the patients are bedridden, their response to levodopa is not happening, then again the role becomes little less. Their response to stimulation, whether it is invasive, non-invasive, comes down. So I think there's a window in between where you can use that option.
Okay. So it's important to understand that optimal
window for each patient.
Okay, understood. And we're talking about a lot of therapies and a lot of multidimensional approach towards treatment. Are there any pitfalls related to treatment or something that neurologists maybe can look out for in the future in terms of treatment, and especially rTMS?
There are challenges, because we know if there is a device already in place, like for example, post-DBS patients, the current understanding is that rTMS is not a thing. There's a relative contraindication. Probably they may say low frequency and away from but the lead is placed exactly in that area where we stimulate the motor area, a little bit closer. So there is a little bit of fear of interfering with the stimulation DBS or burning the device, and also there is a fear there. So that becomes a challenge. So we'll have to probably modify that, or we want to have some new ways of doing it, whether it is using a lower frequency or a single pulse, not using recurrent pulse like 1,000 pulses or 3,000 pulses like we use generally. So we probably can use a single pulse, something like that, or whether you switch off the battery. So probably we need more evidence and more experience with that. So that may be an area where I think, because sometimes post DBS also after many years patients do progress and they develop more problems, motor symptoms, non-motor symptoms and all. And we try to adjust parameters in DBS, but sometimes we may come to a stage where we may not help, how much you do adjustments with medications or stimulation parameters. But then we can look at other options like the thing. But right now, the safety is an issue. So that becomes an area thing.
So it's rTMS is sort of like a management strategy when it comes to such advanced cases.
Yes.
Treatment at that point is slightly less in the picture. It's more about managing the
Yeah,
symptoms. Got it. And are there any non-responders, any patients who do not respond to rTMS?
The experience is not much, but whatever the studies have shown that there can be markers where you can predict, or when you do it and if they don't respond, you can go back and see what you've done differently or what you could have done differently to help these patients with rTMS to have better response. One is there's a significant cortical atrophy. Okay. If the MRI shows there is significant cortical atrophy, because ultimately you are stimulating the cortex. If the neurons or synapses where you're targeting, so you are trying to improve the efficiency of the synapses. Right. While you are doing cortical stimulation using rTMS, you need a good cortex, available cortex, and if things are, and the synapses, if it is not available, then for sure it may not work. Right. Another thing is a clinical phenotype. If there is a significant brainstem involvement, like in some cases of PSP, so there it may not work much. So that is one thing. And the site of targeting, there may be a thing. So you probably rework your things. That's where the newer modalities of rTMS, where they're using neuronavigation for planning your stimulation areas, that becomes handy. And EEG based thing where like for example, we are now using local field potentials in NDBS. Same thing you can incorporate in rTMS, where you can have EEG based targeting. So you have discharges, beta oscillations on the EEG, and then you show that you're suppressing by when you're setting the threshold, and that becomes a very, very specific area of stimulation that you can use it to miss having a poor response.
So we can localize exactly where beta synchronization is most in target.
And another area where we can come over this type of thing is a closed loop stimulation and all. So these are the futuristic thing which probably can made available in the next few years, and that probably can reduce this non-responders.
Makes sense. Yeah. And that's a great thing. The more techniques we try, the more evidence we'll establish, and the more treatment will be available to patients.
Yes.
Right. We've talked so much about rTMS, how it can be used for Parkinson's disease, how you can identify Parkinson's disease, and how you can take care not only as a attender or a caretaker, but also as being the primary neurologist. Can you tell me a little bit about how a usual rTMS session goes, and how long does it take, and over how many sessions does it usually involve?
Yeah. So once the patient is referred for rTMS, usually what we do, usually in Parkinson disease, it is given as a minimum of 20 cycles, 20 to 25 cycles. And the first 1 or 2 days is taken for setting the threshold and having a checklist whether it is safe, because we don't want any patient who have active epilepsy being taken. So the checklist is there. So we make sure that there are no major contraindications.
So we screen them first.
And make them comfortable. That the newer machines are the experience is so good, they don't feel that type of stimulation happening. So once we have done the indication set and we rule out any contraindications, then we set the target, what area you need to be targeted depending on the indications. So if it is idiopathic Parkinson disease, is mostly the motor M1 area. Either we select unilateral, bilateral, depending on the clinical phenotype. So typically, because the time when we select for these patients for stimulation, rTMS is usually bilateral disease. So usually we target bilateral. We can use a little bit more cycles, more pulses to the contralateral, to the area which is more involved. Like if the patient has much more symptoms, motor symptoms on the right side, we can stimulate more on the left side. We can do that type of thing. So usually the M1 area of the motor is selected. But if they have more of axial symptoms and all, we also take into account of supplemental motor areas thing also. And if there is a cognition and all, so we can probably do dual targeting or multiple targeting to cover non-motor symptoms also. So once the target is selected, and also the studies have shown that minimum of 10 cycles at least of 1,000 to 2,000 pulses every day are necessary to have a desired effect. So in our center we are doing around 25 cycles for each thing. So at least 2,000 pulses. So almost it goes on for an hour. And we are using high frequency, about 10 hertz frequency we're using for Parkinson's disease patients. And then we see some response after 8 or 10 cycles.
Okay.
So, and we continue that for at least 25 days. So it will extend till 1 month, because we give 5 to 6 days in a week. So that continues till a month. That's the usual typical planning we do.
Okay. And what about theta burst stimulation? Is that another paradigm?
So now we are using only the routine high frequency stimulation.
Okay.
The intermittent theta burst stimulation has been looked at, but still we don't have enough evidence.
Okay.
And for Parkinson's disease, we are using high frequency stimulation. We use low frequency stimulation only in patients with dystonia who have Parkinson's disease do have sometimes dystonia, but very rarely we have used low frequency stimulation in Parkinson's disease. It's usually high frequency stimulation.
Okay, understood. And exactly what happens at the neural level when rTMS is being used? What are the changes that happen in the brain?
So basically, we're looking at when we're delivering, rapidly changing magnetic field and to deliver current. So we are trying to improve the transmission in the synapses.
Okay.
So we are in Parkinson's disease, we're looking at more dopaminergic output at the striatal level, because that is the reason why patients develop symptoms. So there is a decreased dopamine, and the efficiency of dopamine has come down in these patients. So the striatal cortical output is decreased, and that's the reason why you see these motor symptoms.
Right.
So we're trying to improve the efficiency in the synapses. So it is akin to almost what we're now listening time and again, machine learning in AI. So it's like relearning, so making the synapses to relearn, improve the efficiency, improve the plasticity at the neuronal level at different things. So various, not only just dopamine, whether it is glutamate or other neurotransmitter also get activated by the repeated stimulation. So you do repeated stimulation, and that improves the synaptic transmission, and that improves the efficiency of the synaptic transmission, and that in turn you see the response, whether it is motor or non-motor.
Right. So regardless of the region where we're applying the magnetic pulse, at the neural level, what's happening is the sort of like a long-term depression or a long-term potentiation mechanism.
Correct. So you call this long-term potentiation. So when you do high-frequency stimulation, and that's where you expect the synapses to learn and memorize, improve the memory of the synapses.
Right.
Whereas when you look at long-term depression, when you do low-frequency stimulation, so you're looking at pruning or reduce the things which you don't want to happen, the potential not to happen. And that's where we use that in whether it is spasticity or dystonia. So in Parkinson's disease, it's the other way around. So you want high frequency, you want to excite cortically, you want to excite the cortical areas responsible for the symptoms.
Got it. Makes sense. There's actually a lot for somebody who's not introduced with rTMS. There's a lot for them to learn about what protocols we use and where we use them. But all of this has been very informational for even someone who's suffering from Parkinson's disease. All of this information is very useful for them to understand what are the next steps. Right. So closing off, what do you think is your vision in terms of rTMS for, let's say, 10 decades ahead from here?
No, I think the scope is huge because there is a gap where a lot of patients are not ready or not eligible for invasive therapies. So that's where we can have scope for non-invasive therapies, non-invasive neuromodulation in the form of rTMS. So the indications are things. So what we need is long-term studies and more guidelines and know how long to continue and when to repeat. So all that will come with long-term studies. So I think we once we have that type of data coming in, I think more and more centers can take it up for considering these patients, because the prevalence of the disease as the age, life expectancy is increasing, including our country, where people are living for longer and they want healthier, quality of life.
Right.
They don't want to be dependent on others. That's when all these treatment modalities to keep them going, keep them mobility going. So that's where we can help them apart from the medication. So rTMS can be a complementary treatment modality for these patients who seek out to improve their quality of life. I think I'd see a good future for rTMS in the coming, probably a decade or two, with more evidence and more research happening. We also probably may contribute towards whatever we're seeing. I think the future is bright.
That's really good to know. Is there anything you'd like other neurologists to know about rTMS from your perspective?
I think there are a lot of meetings happening. There are a lot of publications happening. I think they can get back to this type of publications, and if the centers, some of the institutes are also into doing this, some of the research things, so they can be part of the research projects. And if they feel if they can benefit their patients with this type of non-invasive treatment, they can refer patients to the centers where these things are happening. I think it's a great opportunity to be part of this type of advanced therapies. Yeah.
So networking and connection. Because at the end of the day, we all want the better for patients who are suffering from such diseases.
Yeah.
So it was very fruitful talking to you about Parkinson's disease and rTMS, and I feel like the more information we put out there for doctors as well as patients, the better it will be for them to approach it and use it. And thank you so much for being here, Doctor. It was very good talking to you.
Thank you, Nandini, for a nice conversation. Thank you.
Thank you.